Can start?
Yes, you can start. Can you hear me?
Yes, yes, very clear. Good morning. Today we'll have a one-round discussion on chest injury. With us will be Professor Shudev Shah. He's professor and head of surgery at NRS Medical College. And the scenario will be presented by Dr. Ganesh Guru, who is a third-year junior resident at MR Bangalore Hospital. Ganesh, share the screen and read the scenario. Just read the scenario and then wait for the discussion. Yeah, you start.
Good morning, sir. A 32-year-old male with a history of RTA presented to the emergency with severe respiratory distress. On examination, patient is tachypneic, BP 9268 mmHg, pulse rate 105 per minute. I will proceed with this patient.
Now, you see, I think before we just get into this patient, can I make a few general comments regarding trauma and chest injury?
Yeah, sure.
Within a few seconds, you see. Now, what is the burden of trauma in our world? Any idea?
Yes, sir. Trauma is the most common cause of mortality.
Global statistics, yeah. I couldn't get you. Yes, once more.
Trauma contributes the most common cause of mortality all over worldwide.
Yes, try and quantify. Can you quantify that? That will give you an idea regarding how big the problem is. I mean, just roughly speaking, globally, approximately 10,000 people die daily as a result of injury, right?
Okay, sir. So I got muted.
Oh, Dr. Shah, you got muted. Dr. Shah, we cannot hear you. You are muted.
So
yes.
Yeah. So it's approximately 10,000 people daily die of injuries. So just imagine, they are not just injured, they are dying of injury, right? So that is one thing I would like to stress on. And I mean, very quickly coming back to thoracic trauma, right? Now, thoracic trauma, since it is a part of what is called the torso, right? In trauma parlance, it is referred to as a torso. Now, most of the deaths due to trauma, it actually is around 42% of all deaths a result of brain injury. But around 39 to 40%, say almost equal, that is 42 and 40 are almost equal, right?
Yes, sir.
So that is accounted for by torso injury as a whole. That means thorax and abdomen put together.
Okay, sir.
Okay, fine. Now, thoracic injury accounts for how much? Around 25% of all severe injuries, right?
Yes.
Now, in a further 25%, it may be a significant contributor to the subsequent death of the patient. And in most of these, the death is due to hemorrhage.
Okay, sir.
I mean, these are certain things you have to have at the back of your mind.
Okay, sir.
And something more important, about 80% of chest injury patients can be managed non-operatively, right? So it is not that you need to do a thoracotomy in almost every other case. So 80% are managed without thoracotomy. That means only by putting in drains and taking care of hemorrhage. Okay? Is that clear?
Yes, sir.
Okay, now let's start. So here's, you have a 32-year-old male patient who presents to the emergency with severe respiratory distress. Yes, a tachypneic patient with a blood pressure, systolic blood pressure less than 100 and a pulse more than 100. Okay, yes. How do you proceed?
I would like to proceed by following ATLS protocol, which includes a
Obviously,
primary
in
survey with
trauma, that is the
resuscitation.
only thing you have to start with. Yes, okay. Continue.
Primary survey with resuscitation. ATLS protocol starts with the primary survey with the maintenance of airway with the cervical spine stability, followed by maintenance of breathing with ventilation, maintenance of circulation and control of hemorrhage, neurological disability evaluation, exposure under controlled environment. Initially, on coming to airway, I would like to assess the airway of the patient by opening the oral cavity, clearing if there are any secretions, foreign body, ill-fitting dentures, I would like to clear it. Then I would like to make the patient's airway maintenance manual like chin lift and jaw thrust. If it seems like a patient's tongue is falling backward, protruding, falling backwards, I would like to use Goodell's airway to prevent the tongue from falling backward. Simultaneously, I will ask my colleagues to attach the monitors to the patient to record the saturation of the patient. After all this manual, I would like to reassess the airway of the patient if the saturation is improving or not.
Yes.
If the patient's airway is improved, then the airway component of the ATLS is done. Then we will proceed on to the breathing part. In this, I would like to expose the chest and neck of the patient to look for the breathing movements, whether chest movement is sequential in both the sides of the chest. Look for any signs of external injuries like bruises, contusions, or anything. Then I would like to palpate the chest for any tenderness, crepitus, anything is there. Then I would like to percuss for any dull note, hyperresonant or
No. In breathing assessment, the detailed chest examination is not required. The first is the primary breathing assessment only. Whether he is breathing at all, whether the saturation is showing any hypoxia.
Yes.
Okay, it's not the detailed chest examination and the primary survey. Okay.
After once breathing part is over, like both the parts of the movement are moving correspondingly with the respiration, and there is no signs of crepitus or anything, I would go to proceed with the circulatory part of the maintenance. I would like to give 2 large bore IV cannulas. Simultaneously, I will collect blood for blood grouping and matching. Basic, I will ask the sister to send for the basic investigations like CBC, blood glucose, urea creatinine. Further, based on how the patient is responding to all through this, further I will go with this. Since this patient is entering at 92/68, I don't think the patient is in severe shock.
Yeah, he's not in severe shock, definitely, but he is in borderline shock, and at the same time coupled with tachypnea. So obviously these two systems are in problem, isn't it?
Yes, sir. I would like to give a saline bolus of around 1 liter to maintain the circulation.
Yes, and then you do. I mean, as soon as you go for the examination of the respiratory system, as you were talking about regarding whether percussion and auscultation, I think that is going to give you some clue regarding what the patient is suffering from, right? Okay, and that needs to be quickly followed up with what? In the primary survey, you have to quickly get on to what is called EFAST. Yes, what is that?
Extended fast, in which we will look at the 6 parts of the torso, right and left, right sided pleura, left sided pleura, pericardial window, perihepatic space, perisplenic space, and pelvic space to rule out the life-threatening injuries.
So what do you expect to find in this patient? Let us talk about that.
Patient is in respiratory distress, maybe.
Yes,
so there might be underlying thoracic trauma, some thoracic trauma might be there.
Exactly. Now let us come to the specifics. A patient tachypneic and who is having a systolic less than 100, a pulse which is more than 100. Yes, in this patient, what do you expect to find in EFAST?
Sir, collection of fluid in the pleural space.
Collection of fluid in the pleural space. Don't forget.
In the trauma setting, usually blood in the pleural space.
The patient, yes, obviously blood. The patient here is lying supine, yes, right? Sir. Okay, fine. So when you are doing EFAST, what do you expect to find?
Sorry, hemothorax or
Along
hemothorax
with
can.
EFAST, you have to also add what you have seen on clinical examination. For example, on clinical examination, you must have seen the position of the trachea in the suprasternal notch.
Yes, sir.
Yes. So if that is deviated, this has to be coupled with your EFAST findings, right? And also on percussion, you must have found maybe say, for example, if there is a hemothorax, remember this blood is going to collect at the bottom,
Yes,
right? So you will not get dullness on the top. So here the lung will be floating up. Whatever lung is there, I mean, is floating up. So you might get a normal resonant note.
Okay.
Okay. So I mean, this with EFAST will tell you that yes, there is blood at the bottom of the thorax. Okay, fine.
I think Dr. Shah,
Yes.
once the primary survey is over, before he goes to secondary survey, in view the patient is tachypneic, he has to exclude underlying some life-threatening conditions like tension pneumothorax, massive hemothorax, and pericardial tamponade. And this will be done by a part of clinical assessment, as you are trying to say at the time of primary survey. You have to do a detailed examination to exclude this tension pneumothorax. How do you diagnose tension pneumothorax clinically?
So clinically, tension pneumothorax, tracheal, on inspection, trachea will be shifted to the opposite side. Reduced chest wall movement on the side of the
this may not be, this tracheal shift may not be there initially. That is something you have to remember.
Yes, sir.
Right at the beginning, you may not get a tracheal shift.
Reduced chest wall movement on that side, tenderness on palpation. In case of tension pneumothorax, there will be hyperresonant note on percussion. Air entry will be reduced. Then the patient will be in hypotension, elevated JVP, and the respiratory rate and the heart rate will be raised.
Patient may be cyanosis. Okay, because of the compression of the opposite lung.
Yes, cyanosis is also a late manifestation. That is something you have to remember. What about the neck veins?
Sir, enlarged neck veins.
Not enlarged. We don't call them enlarged. Huh? Distended, yes. Okay, fine. Now proceed.
How do you take measure if you find patient is having tension pneumothorax? Before you send this patient for X-ray or whatever, patient will die there. So you have to relieve the tension pneumothorax.
I would like to proceed with needle thoracentesis by inserting a needle at the 5th intercostal space at the mid-axillary line.
Needle is not put in the
large caliber
5th intercostal space. So if you do a needle, immediate relief, it's not in the triangle of safety. That will be done in the parasternal region. Second intercostal in the mid-clavicular line. Yeah.
Yes, because here remember that the patient is supine, so you have to do it on the top. Okay, and don't go very medial. In that case, you might cause injury to the internal memories and all that.
Yeah.
Right. So you have to put in a large bore needle, and if possible, put in a catheter through the needle. Right, if that is possible. Ultimately, this will suffice if there is an actual pneumothorax, tension pneumothorax. You must. This should be followed up with a intercostal drain. Right. Okay. Yeah. Yes. Next.
Sir, if it is tension pneumothorax, then I will.
A few words about pneumothorax. What are the different types of pneumothorax we usually come across in case of chest injury?
Sir, open pneumothorax, tension pneumothorax, hemothorax.
We say pneumothorax only.
Yes, sir.
We are talking of only pneumothorax. Yes. Okay. Now, what is tension pneumothorax and what is the other pneumothorax you are talking about?
What is the difference between tension pneumothorax and you say simple pneumothorax? Because of just a blunt injury, or there is another called open pneumothorax.
Simple pneumothorax usually occurs in even a normal patient who are having any blebs or something like it, usually present in the trauma setting. Whereas case of open pneumothorax, there is a creation of sucking wound. When the size of the wound is around 2/3 of the diameter of the tracheal diameter or more than 3 centimeter, there are chances that this wound might be causing sucking of air into the pleural cavity. So it will be leading to open pneumothorax. Tension pneumothorax is a open pneumothorax with rapid hemodynamic compromise is tension pneumothorax.
No. In tension pneumothorax, you have a situation of pneumothorax where there is leaking of air from the lung, but it's not returning. So this is building up pressure in the pleural cavity, and this lung is collapsed, and continuing further, this causes compression of the opposite lung and the heart. The heart is pushed to the opposite side. So that is the difference.
In simple words, the leak is one-way valve. Right? Okay. Now just tell me one or two possible conditions where whatever you have done something and you have actually converted a simple pneumothorax into a tension pneumothorax. Is that possible?
Yes, sir. In case of underlying pulmonary laceration and if the pleura is intact, if you are giving intermittent positive pressure ventilation without putting an ICD, it may convert a simple pneumothorax into tension pneumothorax.
Yes, when there is already a simple pneumothorax, without putting in a drain, you have instituted positive pressure ventilation. That is one. And number two, say when there is a sucking chest wound, right? So without putting in a drain, you have somehow tried to repair this sucking chest wound. Okay. So even in these conditions, these two conditions, you can just convert a harmless simple pneumothorax into a life-endangering tension pneumothorax. Okay, fine. What is the commonest cause of tension pneumothorax? As you said, it is mechanical positive pressure ventilation in case of visceral pleural injury, right? Without instituting, without putting in a drain. Okay, now proceed.
Sir, the patient is after the ICD is given, if the patient is getting stabilized, I would like to go with the other parts of the management like supplemental oxygen, adequate analgesia, skin care of the patient, will proper nutrition, suspected infection. If I'm suspecting infection to be there, I would like to start with the antibiotics. I will start PPI since these patients are more prone to stress ulcers.
Then you have not done the secondary survey, right? To understand.
No.
You are given a scenario of tension pneumothorax, you have done a primary relief.
Yes.
So what is the component of secondary survey when you suspect a chest injury?
Sir,
in secondary survey, what do you do?
After stabilizing, I will proceed on with the definitive investigations to find out the underlying injury.
Secondary survey will include the detailed history, the mechanism of injury, what other symptoms he has, other medical history. So you have to do a detailed secondary survey because patient's got respiratory distress. He may have other injuries. So in secondary survey, your other global assessment has to be done for this patient. And then you plan for investigation. So if the patient has got a specific chest injury, what are the steps for a proper chest examination?
After clinical examination?
Yes, proper chest examination include what? So I'm not going to the abdomen for this patient. I'm confined to the chest. What are the important points in chest injury you will be looking for?
So after thorough history with the clinical examination, proceeding with inspection, palpation, percussion, auscultation, then I go with the radiological finding.
What clinically?
Clinically, on the history, the patient might be.
History is done. History is done.
Clinically, on inspection, there will be reduced movement of the chest wall on the side of the injury.
Yes.
A tracheal shift to the opposite side can be seen.
Don't jumble up things. You started saying inspection. Inspection, don't look for trachea.
Sorry.
Inspection is you look at the chest, any bruise, any laceration,
Contusions.
okay, any contusion, then movement of the chest, whether that side is moving or not. Okay, this is in inspection. And then you go to palpation, you can start with tracheal position. Tracheal position, apex beat, whether there is any mediastinal shift. And then you look for tenderness, assess for any refracture. Yes.
And then fractures.
Yes.
Then,
come on.
Then on percussion, I will
yes.
percussion.
Percussion is important because the mediastinal shift can occur either in the pneumothorax or in the hemothorax. The percussion will give a lead whether it's a pneumothorax or it's a hemothorax. And then breast sound will be absent in both if you have massive pneumothorax. Okay.
Yes.
What next? You suspect the patient might have some collection in the pleural cavity, likely to be blood.
Yes, that is what I'm trying to say.
Yes.
That as soon as you put in a drain,
yes, sir,
as you said, you have put in a drain through that triangle. Now,
Yes,
can you just tell us the boundaries of the triangle?
sir, anteriorly anterior axial fold constituted by the lateral bud of pectoralis major, posteriorly posterior axial fold constituted by the lateral bud of latissimus dorsi, inferiorly by the upper fifth intercostal space, apex is by the axilla.
Yes. So through this
I think
triangle
it
of
is upper
safety,
part of thickness.
Fifth intercostal.
so in both cases, the diaphragm will form the lower border, isn't it? In both sides, right? If you have fast, you can very well confirm that. So that is how you put in a drain, and make sure that you will use all standard procedures in putting in a drain. Like you'll have to give whatever anesthesia is necessary, local anesthesia obviously, and make sure the procedure is perfect. That is, you will go above the lower rib and not below the upper rib, right?
Yes, sir.
Can you tell us why?
So the neurovascular bundles are lying along the lower border of the rib. In order to prevent
Yes.
injury to this neurovascular bundles, we are putting in the chest.
Yes. So you have to make sure that you go through the upper border of the rib and not through the lower border of the rib. Okay, right, fine. So what size will you use in an adult patient?
If it is an hemothorax, I would like to give 32 French drain. If it is in case of pneumothorax,
Listen, you don't know before you are putting in a drain what you, because in a trauma patient you can always expect hemothorax, right? So
32
in an
French.
adult patient, what would be the size that you will choose?
Sir, 32 French tube.
Now listen, your answer should be, in an adult male patient, it is anything between 28 to 32.
Okay, sir.
Right? In a female patient, it may be, yes, 26 to 28, right? Okay, nothing less than 28 in case of a male patient, and nothing less than 26 in case of a female patient. Because in that case, they will become very narrow and they might not serve your purpose. Okay, so as soon as you have put in a drain, so what is going to come out? Air and blood, isn't it?
Yes.
Okay, so what volume of blood that comes out through the drain will prompt you in doing something else?
Sir, in case of a blunt injury, after inserting the ICD, the amount of fluid, the amount of blood coming out is 1.5 liters. In case of penetrating injury, if it is more than 1 liters, or the amount of blood through the drain is 200 ml for 3 to 4 hours, or 100 ml of blood in the 15 minutes consecutively for the first 1 hour, I would like to proceed with the definite thoracotomy.
So as far as bleeding is concerned, these, as you have just mentioned, these are indications for emergency thoracotomy. Okay, fine. So anyway, so you suppose you find 1.5 liters of blood that has immediately come out. Now, just slightly deviating,
Yes.
Who is authorized to do a thoracotomy? Will you do it?
Sir, I would like to have a help of the cardiothoracic surgeon.
Yes, always it has to be an experienced person, right? Okay, fine. Now coming back. Okay. Now suppose after you have put in a drain, right? You have instituted underwater seal drainage. Huh? Okay. Now, if there is bleeding, obviously you have to initially you might give crystalloid, but you will give crystalloid only for the volume of crystalloid that is allowed initially.
Sir, around 1 liter of crystalloid only allowed.
Not more than 1.5 liters. Okay, fine. Then you have to go for blood. Fine. Okay. Now, what else will tell you that patient might also need emergency thoracotomy apart from the bleeding? If you set aside the bleeding part, what else will tell you that this patient may need an emergency thoracotomy? You get my point?
Sir, if it is an air leak is massive, then the patient might be requiring that.
Massive air leak. Yes. Massive
What
air
else?
leak,
What
which
else?
is not else. Yeah.
We've done a CT scan and there were some other findings.
Sir, if there is any tracheobronchial injury or any other injury which I want to immediately, which I want to repair, primary repair, then I would like to do the
Tracheobronchial is air leak. What else?
So, aortic injury or esophageal rupture.
Yes. Actually, esophageal injury or major injury. These are the indications for doing thoracotomy.
Now, there is a term called deadly dozen.
Yes, sir. So
Yes.
immediately
Sure,
life-threatening, potentially life-threatening. In the immediately life-threatening, airway obstruction, tracheobronchial injury, open pneumothorax, tension pneumothorax.
Hold on. So as you have rightly said, the first 6 or half a dozen is life-threatening, and the other half a dozen is potentially life-threatening, right?
Yes,
Okay. So the first half dozen is something you have to detect on the primary survey. On the primary survey, right? And the second half dozen, you are supposed to detect in the secondary survey. So these things are also important.
Okay.
Right? Apart from the way you are mentioning all of those, that is fine. But you have to keep in mind these things also.
Okay.
Right? Okay, fine. Continue. Now, regarding as Makhanda just now mentioned, a CT scan has been done.
Yes, sir.
Right. So in the primary survey, you are supposed to do a clinical examination, and you are just allowed 1 or 2 investigations. What are those?
X-ray chest, X-ray pelvis. In case of suspected cervical spine injury, we may proceed with the X-ray neck, AP lateral, after stabilizing the neck with the collar.
Yes, you're correct. Certain straight X-rays. Right. Remember, the patient is horizontal, right? So in this position, you may undertake certain very important X-rays that you may consider is appropriate. And what else? We have just mentioned that is fast.
Yes, sir.
So these
And there is a recommendation that the first should be done within 30 minutes of patient arrival to emergency. That is a standard of care.
And it should be done along with your clinical examination.
Yeah.
Right. You have to decide which part has to be investigated immediately, whether it is the thorax or the abdomen or both. Okay, fine. Now regarding CT scan, usually done after the primary survey is over.
Okay.
Now previously it was told that don't send a patient to CT scan until and unless the patient is hemodynamically stable. So what is the present view?
Sir, in the present view also, we can't send the patient to CT if the patient is hemodynamically unstable. If the patient is hemodynamically stable, doctor should be accompanying the patient all the time while going to the CT scan room. Yeah,
you're correct. You're absolutely correct. Now there are certain minor changes because nowadays in modern centers, the CT scan is incorporated within the trauma center, right? So that the patients who are borderline hemodynamically unstable, you can, because we have rapid CT scans which are done very quickly these days. And what is advised is basically a whole body CT scan,
yes,
right from the head to the pelvis. And it has to be with contrast. So you may write a whole body CT scan, send the patient, of course, accompanied by someone, and only those who are not seriously unstable. Okay, and seriously unstable, you have to make it stable and then send. So there is a slight modification there. Okay, continue.
Yeah, then I think we should, apart from this pneumothorax and hemothorax requiring thoracotomy, we can have some discussion on the isolated rib injuries, flail chest.
Okay. Oh, definitely, yes, we are coming to that.
Yeah.
So how will you diagnose a flail chest, as just Makhanda mentioned? What is a flail chest to start with?
What is flail chest?
So flail chest, according to Bailey definition, fracture of 3 or more consecutive ribs at 2 or more places, causing paradoxical respiration. Flail chest, or either maybe in ATLS they have given like 2 or more ribs at 2 or more consecutive ribs at 2 or more places, or a costochondral dysfunction on both the sides of the sternum, which act as like a central flail chest. Fine. So how does that affect the patient? Sir, you have segment of the chest wall is separated from the remaining chest wall. So since inspiration is active process, that part of the chest is not expanding during the inspiration, is not getting ventilated properly. So ventilation perfusion mismatch occurs, which in turn leads to hypoxemia. Okay. So how does one diagnose this? Sir, paradoxical respiration, the patient will be showing signs of respiratory distress, tenderness in the chest wall, reduced movement of the chest wall on that side.
This is one of the inspected finding. When you have a flail segment, if you look at that part of the chest wall, you will find that that segment of chest wall will be sucked in during inspiration, and the segment can move out during expiration. So that is why does a paradoxical movement occurs?
So that segment of the rib cage is separate from the rest of the rib cage. Respiration, breathing is an active process in which the inspiration is an active process.
Yes.
In which the lung is getting expanded. There is a negative intrathoracic pressure.
Yes, that is the point. The intrathoracic pressure becomes negative during inspiration, but still the thorax moves out because it's an active process. The flail segment being separate from the rest of the chest wall because of negative intrathoracic pressure, this will be sucked in and causes compression of the lung over that area, preventing the expansion of the lung with air. So this is because of the negative intrathoracic pressure. And when the patient is taking expiration, the intrathoracic pressure changes to positive. That's why this segment is now pushed out. And this flail segment extent will determine, you say the ventilator performance mismatch. Whether this mismatch is causing hypoxemia or not will depend on the extent of flail chest.
What percentage of flail chest is part of the whole thing? Okay, if you have a large flail segment, it is going to affect the patient more. If you have a small flail segment, it may not affect at all, right? So this is the essence. And now one more thing, how do you diagnose that? As you have said, that you can look at the features, that is, hypoxemia and all those things. Apart from that, remember that in case of obese patients, it is very difficult to diagnose a flail segment, right? That is something you have to really, in patients who are lean and thin, fine. I mean, just you have a look and you can make out. There's nothing wrong in that. I mean, that is very easy. But in obese patients, because the area is already bruised, okay, so it is very difficult to diagnose in case of obese patients. Okay, fine. If you find that, yes, this flail segment is causing hypoxia, the main cause of hypoxia, and then the problems come regarding treatment. Yes, what do you do to treat such flail segments?
So, and then as Dr. said, if you cannot diagnose on inspection, in that case, if you suspect a flail chest, you should do a chest X-ray and a CT.
Yes.
This will give a correct diagnosis of the underlying flail chest.
Now, as Mahmunda said, you will do a CT. Now, would you like to write something else apart from just a CT scan? Anything else you have to mention just for flail segment?
3-dimensional CTs. Yeah.
3-dimensional CT with the bony configuration, right? That is something you have to mention because you would like to look at the ribs in particular. Okay, now proceed regarding management.
So, management, supplemental oxygen, adequate analgesia, preferably thoracic epidural anesthesia. Previously, they thought if the patient is having flail chest, want to be put into ventilation, but now patients are treated with the intermittent positive pressure ventilation. After with the intermittent positive pressure ventilation, if the patient's PaO2 is less than 60 mmHg or the respiratory rate is more than 80, then the patient may be ventilated. Or if the patient is going with his conservative management, we will look at the other components of the treatment, in antibiotic, PPIs, and nutrition and skincare of the patients. Treatment of the other.
Positive pressure ventilation will be my last resort, right? Before that, what I will do, I will make sure that the patient, I will give adequate analgesics,
yes,
both mostly regional here, right? Make sure that you give some intercostal blocks or certain other things without affecting the consciousness of the patient. Okay, so regional pain control, very important, right? Apart from that, remember the positive pressure ventilation will be my last resort, not before that. Okay, so in between you have a number of things to be done. Fine.
Okay.
Okay. Now let us proceed to something else which might cause problems. As you said, in the first half dozen, we have talked about pneumothorax. We have talked about all forms of pneumothorax. That is, we have talked about flail chest. What else can we have?
So pericardial tamponade.
We can have a tamponade, yes. Right. So if there is a tamponade, the only way to diagnose a tamponade is by, confirm the diagnosis is by a sonography, right? Okay. So you have diagnosed a tamponade. I mean, before that, what are the features you find with tamponade?
Yeah.
What are they different from pneumothorax? The features you find in pneumothorax.
What is big stride?
Big stride, hypotension, elevated JVP, muffled heart sounds constitutes the big stride.
Yeah.
Yes. Okay. So, and this muffled heart sounds are very important, right? They are usually not found in pneumothorax until and unless it is shifted a lot. Okay. So, what will you do to manage this tamponade?
Under echo guidance.
Pericardiocentesis. Yes, that was the usual method of doing it some time back. But nowadays, what is the problem with pericardiocentesis?
Sir,
just put in a needle and remove the blood. That should solve
we may
all
accidentally injure the heart. It may lead to
arrhythmia. Pericardiocentesis, it is understood. It always has to be guided. It can't be blind.
No guidance.
Okay. So it has to be guided. Yes. Now you are doing a guided pericardiocentesis. Okay. You have removed some amount of blood and then you find nothing is coming out through the syringe or through the needle. What does it mean?
So,
it means there is a clot, right? So, I mean, that is the problem, with pericardiocentesis. Some amount of blood will come out, but that will not be enough. So nowadays, if you have diagnosed a clear diagnosis of what is that? Tamponade, yes. If you have diagnosed a tamponade, remember it has to be removed surgically.
Okay.
Right. Otherwise, it is not possible. Because it is rarely that you find that by aspiration you can remove the whole blood. In most of the cases, you have to call for a CTVA surgeon, and it has to be an operative removal. Right? Pericardiocentesis usually does not suffice. Right? So here also you have to undertake a operation. Okay. Whether your approach will depend on the amount of blood you expect, or the amount of blood you have seen by sonography. Okay, fine. Yes, Mahunda?
Yeah. What do you mean by stove chest?
So stove chest is fracture of a multiple ribs at a single segment. Only one side of the chest is involved. It is an indentation, so causing the underlying pulmonary contusion.
So it's a multiple rib fracture at one point where that part of the chest is pushed inward. Will it be showing a paradoxical movement?
No, sir.
No. But it can interfere with, again, gaseous exchange because of the underlying lung contusion or the extent of the stove chest.
So remember, in both these conditions, flail chest and stove chest, what is the ultimate problem? What will decide, or what kind of, what injury that the patient has sustained will decide in the long run what is going to happen. It is not what you are seeing from outside. It is actually the lung injury that is going to define, right? That will tell you what the outcome is going to be. This is something you have to remember that's very important. Okay, it is not just what you're seeing from outside. You can see just a few fractured ribs here and there, either causing a flail segment or a stove chest. Remember, there is a much more serious lung injury inside. Okay, right. You have this single slide, or you have any other slides?
No, just one scenario.
Just one slide. Okay, fine. I mean, in the next half dozen injuries, right? In that dozen, what are those injuries which you may come across? The ones which surgeons usually encounter is diaphragmatic injury, right?
Diaphragmatic injury.
Tell us something about diaphragmatic injuries.
Yes.
What can you expect?
Sir, usually diaphragmatic injuries occurs in case of a penetrating injury just below the nipple up to the rib cage, or in case of severe blunt injury of the abdomen also due to the internal pressure, there may be diaphragmatic injury. When the diaphragmatic injury is occurring as a result of blunt injury, the diaphragmatic tear is usually a larger tear and it will present little early. In case of penetrating injury, the penetration may be small, it may be presenting late also.
Yes, you're absolutely correct. It may be presenting late. Okay, how does one diagnose diaphragmatic injury?
Sir,
now, in certain cases, on a chest X-ray, things become very easily visible, right? you may find some part of the abdominal content has moved into the thorax. That is one. Next.
Coiling of Riles tube. If it is
Before Riles tube, what symptom patient? Suppose
patient
patient has got a major
respiratory
patient has got a
distress.
major road trauma, and these are patient who came with tachypnea. You see, this patient having tachypnea may have the primary lung injury,
And the associated.
or if the patient has got a diaphragmatic tear, what is going to happen? Again, same mechanism. Because of negative interthoracic pressure, more and more abdominal contents are sucked into the chest. And what does it result in?
So it will again lead to the reduced ventilation. Everything.
Yes, it's really on the affected side. So patient is very distressed. What do you find on examination which may suggest that there is possibility of diaphragmatic injury?
So bowel sounds will be heard on Oscar.
Yes, that is one very important finding. So if the patient has got a gut segment being pushed in the chest or in the hemothorax, you can hear
Bowel
sounds apart from the normal breath sounds. So there is a point of suspicion. You cannot have a specific finding of diaphragmatic injury apart from finding bowel sounds in the chest. And then you put a Riles tube, you can find that the Riles tube is
coiling up Riles tube.
coiling up in the hemothorax. And
Or,
then,
it may not be possible to insert a Riles tube at all.
yeah,
Right, because due to the acute angulation, the Riles tube is not going in after a certain length has gone, right? Okay.
and when you are looking at the chest X-ray, one has to be very vigilant. In the chest X-ray also, you can make out the diaphragm rupture by looking at gas-filled loops in the hemothorax. And then confirmation is by contrast CT. If you give the oral contrast CT, you can see the GI tract into the thorax. So what should be the you have diagnosed diaphragmatic injury in acute setting.
Sure.
And you have gone through other systems and you find that is likely to be isolated diaphragmatic injury. What should not be done?
Bag and
Because
mask ventilation should not be done.
No. That may be done. What should not be done? Because this has resulted in number of injuries. Because most of the time, this is getting patient is tachypneic, having respiratory distress. So there are some situations people put chest tube without doing the investigations. That should not be done. Because you're trying to put a chest tube in this situation, you can
will perforate the stomach.
Yes.
Yeah. So before you investigate, you should not put a chest tube. But there are, you see, you are thinking of tension pneumothorax. You don't wait for the chest section to come. You put a chest tube. But in patient has got
remember, tension pneumothorax is a clinical diagnosis, and it calls for initial management before any kind of investigation is done.
Yeah.
Right. So that is a clinical diagnosis. That's something you have to remember. Okay. Right. How can you miss a diaphragmatic injury? There is a diaphragmatic injury, but somehow you have missed it.
And you are missing. This patient present after 2, 3, 5, 10 years.
Yes, exactly.
So what do you mean? This means you are not suspecting, number one, you are not suspecting patient has minimal symptoms. Okay, there is some injury and some amount of gut is pushed in, patient does not have a respiratory distress, and you did a chest X-ray, you missed this small gut loop in the chest segment, CT was not done. So you can, and if the patient is recovering from the injury, then the situation that you missed the diaphragmatic injury. And what happens afterwards is that if the diaphragmatic injury is there, this herniation can keep on increasing over a period of time. So that time you come to the situation that patient has other symptoms like respiratory distress, early satiety, features of bowel obstruction, even patient having a diaphragmatic hernia, patient may have features of gastric volvulus. The other patient who can present with acute gastric volvulus.
And once this viscera has stayed there for some time, they become fixed to the surrounding structures and they do come out. They will not get into the abdomen by any maneuver. Right? Ultimately, you have to operate and correct that. So, and moreover, in certain cases where there is an injury and nothing has got into the thorax, even in that case, you will miss. Maybe something will get into the thorax after a period of time.
Yes.
Right? Okay. Fine.
Okay.
Anything else?
Yeah, no, we have covered almost. The other usual question is there's in the ward round scenario. Dr. Maiti, you like to add anything?
No, both
Maiti,
professors.
sir?
Yes, no, both Professor Sahas and the presenter has made today's discussion very illuminating, lucid, and we have covered almost all the practical and most important practical points related to the chest injury. Thanks a lot.
Boshak, sir? Dr. Boshak? Any question from any of the students? Any question, any clarification?
Probably you have asked mediastinal flutter, that term, mediastinal flutter, it was discussed. I may have missed.
No, we have not.
Flutter.
No, you have not. Just tell us.
So the student can tell what is mediastinal flutter for the just for discussion. I hope all of you know it.
Mediastinal flutter.
Don't know.
He said he don't know.
Oh, you don't know. Any other student? It is simple. It is mainly associated with the frail chest when there is paradoxical movement and associated with some sort of pneumothorax too. Then with each movement of the frail segment, the mediastinum also moves to the opposite side. And when the frail chest comes out, the mediastinum moves towards the same side, ipsilateral side. In that way, mediastinal shows a continuous fluttering from left to right, and that causes disturbance a lot to the cardiological function. So the cardiovascular system may be indirectly affected by the respiratory problem.
Okay. Thank you, Dr. Shah. Thank you very much.
Okay. Thank you.
Thank you.
Sir, one question.
Yes. Who is?
Deepak, sir.
Oh,
Sir,
Deepak. Yes.
Sir, what is the ideal fluid in trauma setting?
Ideal fluid.
They have asked what is the fluid of choice.
You see, now the concept of crystallite resuscitation is going out. Initially, when the patient is in emergency, you can give a fluid which is having sodium, potassium, sodium and chloride. It may be either a normal saline or a ringer solution. Okay, but you should not give the patient massive crystallite. This has got number of consequences. The concept is now changing more towards massive blood transfusion. In trauma setting, the shock is because of blood loss. And people are now coming with the idea that you resuscitate in emergency with 1 to 1.5 liters saline and then start replacing the blood with PRBC, platelets, and plasma. 1:1:1. Okay, and then for maintenance,
Sir,
you have to give the
sir.
filter. For maintenance,
Sir,
yes,
will write normal saline or RL?
normal saline is good enough. You can give normal saline. Unless the patient is having acidosis, normal saline is a acceptable fluid.
Okay, sir. Thank you, sir.
One other comment I like to make regarding the delayed presentation of chest injury. I have experience of one patient. The patient had multiple injuries, abdominal and the chest injuries. But chest injuries, is so trivial, appear to be so trivial that we are concentrated on the management of the abdominal injuries and head injuries. The patient, actually we have lost the patient after 2 or 3 weeks, and on post-mortem examination, as it was a police case, on post-mortem examination, it was found to be pleural collection of the blood, significant amount of blood causing the respiratory problem. So that may have slow leaking of blood, slow spillage of blood from the intercostal vessels, sometimes may surmount to a significant amount, and that hemothorax may be slow to accumulate to be a big one. So that should be remembered. Initially there may not be any findings in the chest, but later because of the slow accumulation of blood, and when it becomes significant, that can produce the chest symptoms. So initially in the X-ray there was nothing. There was no hemothorax, no collection, but later on post-mortem examination found there was the collection.
So the dictum in trauma is a continuous assessment of the patient. Patient should be kept in a high dependency unit and you have to do a continuous assessment, because these injuries which are coming up subsequently has to be detected by both clinical examination and, if required, a subsequent investigations. So a continuous monitoring is important to detect this type of trauma.
Dr. Sudev, if the question is asked, what is the commonest cause of hemothorax? It is intercostal vessel injury or the lung injury? Any study? If a question is asked, what is the commonest cause for hemothorax? Is it isolated intercostal vessel injury or the lung injury?
The commonest cause of hemothorax.
Hemothorax.
This building in the hemothorax is commonest is intercostal vessel injury.
It may be from both. But
But the common is intercostal vessel injury because of refracture or chestual injury.
But the question is coming to my mind, then what can I answer?
Because lung condition is not that common in blunt chest trauma. More is refracture and the associated chestual trauma.
Thank you, Dr. Saha. Your classes are helping us learning more and more.
No. You are one of the teacher in the session.
No.
One last question.
Yes.
What is PEA, or usually referred to as pulseless electrical activity? That means the idea, what is it? You have put in an ECG and you find that there are small elevations. Wherever you are expecting a PQRST complex, instead of the whole complex, there are just small elevations coming up. But on examination, you find there is no pulse.
Yes. Pulseless electric activity.
Pulseless.
That means these are the cardiac activities.
On an ECG.
These are the cardiac activities. Cardiac contractility is still there, but it's not enough. It's not enough to throw the blood to the periphery.
It is not enough to generate a pulse. Right. Now, there are many causes, but in reference to our context, please remember, these things can also give rise to a PEA, that is a cardiac tamponade, a big pneumothorax, right? And what else? And anything giving rise to profound hypovolemia. This is in reference to what we are discussing, that is chest trauma, but there are many other causes. So this is a condition which might you may come across when you are dealing with a massive injury. Okay.
Thank you very much.
Sir, I have a question, sir.
Who is
Yes.
Sir, Sanjay.
Yeah, please.
Sir, when can this chest tube can be removed, sir? After we put a chest tube, what are the indicators that now the chest tube?
The point is, if you take one liner, chest tube will be removed when the purpose has been served.
Makundas, let the speaker answer.
Yeah.
Sir, when the lung is adequately expanded, then we can remove the chest tube, sir.
I think you have to try and learn how to answer questions, right? It's correct. What we have said is perfectly correct. So the thing is, it is better if you answer that we need some evidence that the lung has expanded to its normal extent. You need number one, clinical evidence, and number two, radiological evidence, right? So by clinical, that means you have to examine the patient and make sure that the breath sounds are equal on both sides. That will give you clinical evidence that the lung has expanded, and you have to prove it by getting an X-ray done, right? So these two things are the most important. Previously, when we were students, we were told certain other things also, like you have to clamp the tube and make sure that the patient has slept overnight without any problems. That is again one indication which we usually don't follow these days. So that is the most important thing, as you have rightly said, that the lung expansion, clinical as well as radiological evidence has to be there.
The point is, you have put the tube for some purpose, maybe air in the pleural cavity or blood in the pleural cavity. So air is not leaking now. The air is absorbed, the air is taken out. So lung is expanded. Second is, it was for blood. There is no bleeding further. All the blood has been drained out and lung is expanded. So that is by clinical and radiological. Okay, that answers your question?
Sir, once the lung has expanded fully, will the water column will be moving?
It will move to some extent. You see,
yes.
When the lung is expanded, during expression, there is some change in the pleural cavity. So there may be some movement. It's not that it will become static.
Yes, there is
if the column
change in, hold on. there is going to be some change in the pressure, right? It is the change in pressure which causes movement of the meniscus.
Yeah.
So initially, when you have put in the tube, the amplitude of movement was high, and gradually this amplitude of movement will gradually come down. But if it is patent, even if the lung has inflated fully, there is going to be some change in the movement, because this is actually reflecting the intrathoracic pressure changes. So
Okay, sir.
the amplitude will decrease, but it will be there.
You need
Sir,
to
if the
differentiate between the
movement-
block tube. You see, you have to differentiate the block tube. Sometimes what happens, even if there is a blood in the pleural cavity, the tube may get blocked. So if the tube is blocked, the column may not move at all, in spite of being there is collection there. Okay, so some movement will be there.
Okay, sir. If the column movement is not there, then what it will indicate? It will indicate there is block in the tube, right, sir?
Either lung is expanded or there is block in the tube.
I can also make a comment. When you see that there is column is not moving, you ask the patient to have a cuff. On cuff, some movement you can detect. Then you can come to a conclusion that the tube has done its purpose. He has completed his purpose. It is not moving regularly, but with cuff, some movement you have seen that you have proofs that it is in the pleural cavity, but there is no content, no fluid in the pleural cavity. Now, another question I can ask you, now how to take care of the puncture site on the chest wall after removal of the tube? What will you do?
Circulation of the chest wall. Sir,
Once you take the tube out, how do
The drain opening.
drain opening?
Drain opening.
sir, before opening, we will make sure that we are removing the drain at the height of the inspiration. We will be initially taking a pulse string suture around the wound site. At the height of inspiration, we'll removing the drain. We will close the wound as soon as the drain is removed.
So actually you have to keep the pulse string when you are inserting the tube, extra pulse string. Otherwise, during removal of the tube, you will have to place another local anesthesia. So to avoid that, you place the pulse string initially when you are inserting the tube. That will help you.
Then the idea is to put an occlusive dressing so that the further air is not sucked in from the outside.
Also occlusive dressing should include a paraffin gauze or gel-net gauze, because it's a gauze itself may not be cause a airtight dressing. A gel-net gauze or Vaseline gauze will make that dressing site airtight also.
And make sure that you are not doing it alone. You have to have someone to help you out in this procedure.
Exactly. Good idea.
Thank you. Thank you,
Thank you.
Dr. Maiti. Thank you.
Okay.